So I have well, I'm Ibrahim. I'm one of the hematologists here at UT Southwestern. I work with Taha. And I have the distinct pleasure of introducing Dr. Thomas Coates from the University of Southern California. He's a pediatric hematologist and an expert in sickle cell and thalassemia, as well as iron metabolism. Our disclosures are listed here. Um, And then the main objectives today are going to be discussing sickle cell disease and gene therapy, which is obviously on the forefront and on everyone's mind with recent developments and approval, specifically for lentiviral vector-based therapies and CRISPR-based therapies. So we'll talk about the physiology and the mechanism of that. Also discuss stem cell mobilization in patients with sickle cell disease and then assess the impact of gene therapy on hemoglobin production and vaso-occlusive events and other markers of hemolysis, and then potentially analyze the long-term and short-term effects of gene therapy.
Mm.
So I thought I'd start off by discussing a case. Um, this is a patient that's 19 years old who has hemoglobin SS disease and presents with recurrent vaso-occlusive crises requiring multiple hospitalizations per year, um, up to five in the last 2 year period. He also has a history of acute chest syndrome at age 17 and is on hydroxyurea therapy, but continues to experience quite severe vaso-occlusive crises. And importantly, he has no HLA matched sibling donor available for stem cell transplantation. He's evaluated for enrollment in a gene therapy trial, and then two options are discussed. Um, Lifengia, which is a lentiglobin gene-based therapy that introduces an anti-sickling beta globin, and Casgevy, which is a CRISPR-Cas9 based therapy targeting BCL11A to reactivate fetal hemoglobin production. Um, so I think at this point, I'll ask Dr. Coates to kind of talk about some of the background in these therapies and how we would decide on the optimal patient to proceed with gene therapy.
All right, great. Well, first of all, it's good to see you guys again. Um, this morning, and I'm honored to have been invited. And I have to start off by saying that I do not do bone marrow transplant. We have a separate um, division here in Los Angeles, or at Children's Hospital Los Angeles, that does stem cell therapies, and but we do have both of these studies opened. Actually, we have a couple of other gene therapy studies opened as well for the treatment of hemoglobinopathies. And we're at the present time in our own practice trying to ramp up to get all of these patients um, treated. And we've got almost 200 patients on our list that we're trying to ran through the pipeline. And it's a little bit of a marathon here, trying to decide where to start with these patients. But we're very excited. So I'll run through my read on this and the way things uh, work here. I mean, we have about 300 sickle patients and about 250 thalassemia patients, and so this particular program is, approach is really much on our mind. And our first thoughts about these patients is, where do we start? Because there are some limitations on how fast they can do these things. It takes several months preparation to get the patient, to get everything all ready to rock and roll. And there are delays in getting the product ready. So, if we're hoping we can get around to doing a couple a month, but I don't know how successful we're going to be. But we've definitely prioritized our patients with sickle cell disease. And I think one of the um, issues that, well, I mean, one of the sort of problems that we have here is that now in most places, there aren't people that actually manage patients with sickle cell disease who are also doing bone marrow transplant and gene therapy. It's The gene therapy is like completely separate department, and this is a little bit problematic, especially with the way the rules are set up with respect to who should get gene therapy and who shouldn't. And I have a slide a little bit later on that talks about the current recommendations from the European bone marrow transplant group that we'll go over in a little bit. But we've prioritized our sickle patients, and we feel very strongly that the sickle patients should get curative therapy as soon as possible in childhood and not dependent upon how many complications they have, because the long-term outcome in sickle cell disease is horrible. The median survival in sickle cell disease is still only about 45 years, even in the United States. And these patients in their last years are miserable. As you guys know, you're adult hematologists, so you see the other end of the story. And as pediatricians, they haven't developed as many complications yet by the time they leave our practice. So all of these patients have a shortened survival, and most of them have very severe complications and morbidities when they're in their 40s, and some when they make it to their 50s. And none of that is reversible by gene therapy. So, we think that they should be treated, very early. So I think one of the things that a lot of people don't understand with gene therapy is that gene therapy is bone marrow transplant. It's just a question of what's the source of the donor. But it's also the transplant is different than you'll hear a lot of centers that I don't know if probably you're doing transplants there where you are. Um, it's quite different than transplant for malignancies in that these patients' bone marrows are very hyperactive, and so you need to use very aggressive measures to try to reduce the bone marrow, the number of cells in the bone marrow. So when you give them the donor, give them the new marrow, there's a place for the transplanted marrow to go. So sickle patients, thal patients are often usually on chronic transfusions, and the current recommendations with thalassemia is that we maintain their hemoglobin levels greater than 10 and a half, which we've been doing for a long, long time. That significantly improves the thalassemia survival. And the difference in thalassemia is that with proper iron management and keeping their hemoglobin levels at 10 and a half or to 11 and a half, their survival is the same as the normal population. My oldest transfusion dependent thal patient that I follow is now 67, and she leads a quite normal life, has no iron overload, and is doing quite well. There's not an urgency with thalassemia to get this done. Sickle cell is different. The sickle cell patients can do everything you tell them to do. They can take their hydroxyurea. They follow your instructions to a T, and be found dead the next day. There's about a 16 or 17% sudden unexplained death incidence in these patients. And hydroxyurea doesn't change that. None of the treatments change that, except hopefully a transplant. So it's a different disease. So for the gene therapy, they undergo aggressive conditioning. In addition to sickle patients are placed on chronic transfusion to hypertransfuse them for a month or two before to try to shut their marrow down if they're not already on chronic transfusions. And then 5 to 7 days of myeloablative conditioning to kill off their marrow. And then on this slide, there's several different approaches to transplant, and just to really make the point that gene therapy, this is myeloablative transplant. In this case, we're using the patient's own bone marrow. And the problem in sickle cell disease is really only about 19% of the patients with sickle cell disease have haploidentical bone marrow matched sibling donors. not haplo, matched sibling donors. So in the United States, now this is different in other parts of the world. I know in France there's a much higher, in Northern Africa, there's a much higher incidence of patients having a donor because of just the family structure and the social structure of things over there versus here. But here there are not very many available donors, and we are not. We'll show you the data in a minute. We're not super excited about matched unrelated donor transplants. Haplotransplants, maybe this is gaining a lot more interest here in the United States. Yeah. So this is just sort of a summary of all the various curative therapies, and matched sibling donor transplant is really, if you have a matched sibling, that more or less excludes you from most gene therapy protocols because the feeling is that the outcome is good. And it's important that patients that are going for transplant for hemoglobinopathies, you need to go to a center that's experienced in doing transplants for sickle cell disease. You know, if the only thing that you're transplanting at your center is patients with leukemia and an allotransplant, and you not don't have experience transplanting sickle cell patients, you plan to start doing it there, and have a hemoglobinopathy transplant program, or you need to send the patient someplace that's doing it because of the marrow differences that I mentioned. That's really important. But in major centers doing transplant and sickle cell disease, you can see the overall survival is pretty good. And The issue of there is some graft versus host disease, but it's not too bad. And the latest data that was shown at ASH last year was really, I was surprised at how well these patients were doing. So that would be our first option. And we try to get kids off to transplant um, as early as possible. The data suggests that transplanting them before age 12 to 14 gives them the best shot. And also, they haven't developed complications of sickle cell yet. Um, Unrelated donor transplant, the overall survival isn't as good, and the graft versus host disease incidence, as you can see there, is much higher. And uh, if they're in parentheses are the numbers for patients that are over 18 to 20 years of age, and you can see that the incidence is much higher. Now, this data in the it's very hard. I've tried many times to get a grip on what this data is, and it's very difficult to do because a lot of these studies that are done for outcomes in any kind of transplant, they're not pure studies. There's a mix of patients, that are much older and using technologies and management of iron and all this stuff from 20 years ago, and that's mixed in with patients that are now using more modern approaches, and so it's really hard. I've talked to my colleagues who are transplanters and get wildly different numbers sometimes. I mean, I've had some transplanters that they're telling the patient there's a 30% they're going to have chance they're going to have severe chronic graft versus host disease, which certainly is not what we see at our center, and we do transplant patients that are in their early 20s at least. But this is what the collective data looks like. Haplotransplant uh, was a good option for patients with sickle cell disease because everybody has a mother or a father. I'm always surprised by this data. Their overall survival is pretty good, and their event-free survival is, 80 to 90%, not too bad. There is an issue with the graft failure that they're trying to resolve, but there's a lot of work going on in this space to try to improve that. And then gene therapy, we'll talk about more. This is really very, very exciting data. There's only been 3 deaths in patients that have undergone gene therapy, and none of those were related to the gene product. So we'll talk about those in a subsequent slide. So these are basically the approaches. to curative therapy in sickle cell disease in sort of summary. Um, and I think I already talked about all of these things. So, um, matched donor, if they have it, recommend that you do that in childhood. Now, the big issue with this is fertility with any kind of transplant, because there's a 70 or 80% chance that, or higher even, that the patient is going to be infertile after they undergo the myeloablative preparative regimen. And this is really one of the big points of discussion. And um, for little kids, it really depends on what the parents want to do. Many parents are afraid that their kid is going to realize at age 18 that they are cured, they had a transplant, but they're now infertile, and the child's going to hate them, and there's going to be all kinds of issues. Other parents um, just want to get their kid cured because they want them to live. So this is a major issue. Sperm collection for males is not a problem for teenagers, but egg collection is expensive and generally not covered by any insurance companies, and so that's the main problem with any of these approaches. Um, there is ongoing research, but it's a while off for non-mild. There's reduced intensity transplants that have been tried with some success. The NIH has been doing a lot of work on that, and we're hopeful, but it's not ready for prime time. And there are non-myeloablative preparative regimens that people are doing research on. But the last talks that I heard on this is, everybody wants to achieve this, but it's nowhere near being able to be used. So hopefully they will be successful with that. So um, this is more or less the procedure. If you're not familiar with it, they harvest stem cells from the patient, and for purposes of gene therapy, this is done by plasmapheresis or by apheresis. Um, and it takes several cycles, so they have to put a large IV in the patient, and they pump the blood out, centrifuge out the stem cells, and there's about 0.1 or so percent of your circulating cells are stem cells. So it takes a number of cycles in the apheresis to get enough stem cells in the bag to be useful. Uh, Sometimes the patient, and I don't have these numbers in my head, but it's important the number of stem cells that you transplant. So they have to get, they have the transplanters have a number that they have to achieve. And so sometimes the patient has to come back 2 or 3 times in order to go through enough cycles to get enough stem cells. In preparation for this, they do uh, give drugs to release stem cells. And this was one of the questions that you had in your slide deck. GCSF can be used. It releases uh, uh, all white cells and also stem cells from the marrow. The problem with sickle cell disease is that there's data. GCSF is thought to be contraindicated in patients with sickle cell disease. There were some patients that had breast cancer, two women that had breast cancer that were given, who had sickle cell disease and were given um, GCSF, and their white counts went up to 50,000, and they got the leukocytosis itself causes acute chest syndrome. And those two patients died of acute chest syndrome because of the GCSF. So this is a black box warning on GCSF. Don't give it to sickle patients. Now, if the patients are on chronic transfusions and their hemoglobin S levels are less than 20%, it would be safe to do that. But based upon this history, this word is out there. You just can't do it. So they use Palixifor, which um, in my mind would cause the same problem, but there's just no history of people dying from it. And these act by interacting with the Palixifor, doesn't stimulate neutrophil production, but it interacts on the CXCL4 axis that mediates adhesion of stem cells and neutrophils to the marrow and causes release. So they give them this drug, their stem cells go up, they do the pheresis, you know, two, three times to collect the stem cells. Then there's two ways that you can add the gene. One of them is using a lentiviral vector. These vectors are actually, I think this is really interesting. All this research from AIDS research a number of years ago led to the development of this technology. So there's a positive side to everything, I guess. And what they do is they use a modified um, gammaized beta globin gene that acts like fetal hemoglobin. Fetal hemoglobin, increased fetal hemoglobin decreases sickling through a couple of different mechanisms. And they introduced this gene. I forget it's um, the name of it, but it's not fetal hemoglobin. It's a modified beta globin gene, and so they add these lentiviral vector, which carries the gene for this modified hemoglobin into the stem cells, and then the stem cells start making this different gene. And it also has the advantage of you can tell how successful the transduction was because you can detect this stuff by flow cytometry. And so the stem cells are then making instead of hemoglobin S, they're making this other hemoglobin. So that's gene insertion. That's the oldest gene therapy for hemoglobinopathies. The first patient was treated with thalassemia with this, I don't know, probably 15 years ago, maybe longer. A patient with thalassemia, beta thal major, was treated, and that patient is still alive and doing well. And then the latest thing you've all heard about is CRISPR, these CRISPR approaches. And again, I'm not a molecular biology researcher, so I can't really speak to the details about this, but the CRISPR protein is put into cells by electroporation, and it has on it a couple of guide sequences that allow it to bind to very specific sites on the DNA, and then it's able to cut the DNA and remove base pairs from the DNA, and then the DNA repairs itself. And so that through the classic CRISPR-Cas9, they take the stem cells, mix it with this protein, put an electrical charge through it, and the CRISPR protein goes into the cells and modifies the stem cells, and then is able to be reproduced as the stem cells grow, and that permanently fixes the cells. The problem is that the regular approach to this cuts out more than one base pair, and it can make more than one deletion in the area close to where they want to cause the deletion. And although this has not been seen clinically, the risk of having errors in the recombination process is felt to be higher with this approach. But nonetheless, what this does is disrupts BCL11A, which is the gene that regulates fetal hemoglobin production. And so when you suppress that, then that allows fetal hemoglobin to be turned on, like it is in utero. The BCL11A turns off fetal hemoglobin production at birth and turns on beta globin production. And so this process disrupts that, and so the patients start making fetal hemoglobin, and their fetal hemoglobin goes way up. This same approach works for thalassemia and for sickle cell disease. In sickle cell disease, the fetal hemoglobin is preventing the sickling, and in thalassemia, they converts the patients to essentially making all fetal hemoglobin, and that's the hemoglobin they live the rest of their life on. They have 100% fetal hemoglobin in thalassemia, but it's exactly the same vector that's used for both diseases. And then base editing is the new thing, a little bit newer thing, and this makes a much more precise cut in the DNA, so you don't have all these more random errors. And this is felt to be safer in the direction that people are interested in going. But still, they're shutting off BCL11A just in a more surgical approach. And there's another method which isn't noted here, which is also base editing. That there's only been one or two patients treated this way, where they are actually looking to correct the amino acid defect in the sickle mutation. So this approach is specific to sickle cell disease, and we're all very excited to see what's going to happen with that. We're going to be involved in those trials actually at Children's. But the patients that were treated, the two patients that were treated this way really had dramatic improvement with that approach. So anyway, you prepare their stem cells in the bag, and then you just do the transplant. You put the patient goes to the transplant unit, you do myeloablation as you see on this slide, and then infuse the stem cells. And 2 weeks later, they're making their own modified stem cell, modified hemoglobin based upon the mutations that have, or the modifications that have been made. And this has been pretty successful. So this is just this slide you guys made. It's a really nice slide. It's comparing the two types of gene therapy that are currently clinically FDA approved. It's been now a couple of years for the gene insertion, and then the CRISPR-Cas9 approach on the right. And both of these approaches work for both thalassemia and sickle cell disease. So why don't we go on the main, I guess, row on this slide is has to do with the key efficacy. Everything else is pretty much identical. There have been neither of these approaches have led to any deaths that were thought to be secondary to the gene product. And actually, when you think of the more than 100 patients or so that have been treated by one of these approaches, 3 deaths, that's a much lower death rate than standard transplant, and the incidence of graft versus host disease is zero with this approach. Right, this is in response to one of your questions. This is an excellent recent review by Lucia Di Franceschi in Italy. This is a consensus statement from all of the transplant centers in Europe about who should receive gene therapy. And this is over on the left-hand corner. There's a few things. One of the things you'll notice there is all of these approaches exclude patients that have an HLA identical matched matched donor, and so that's currently felt to be the number one candidate way to cure these patients. And then the other thing that's the regulatory agencies, and they're different in the United States than they are in Europe. But this is a product of the fact that the gene therapy people are not treating the patients. This idea that you need to have 2 hospitalizations per year in order to be eligible for gene therapy, in my opinion, is crazy. I mean, why do you wait for patients to have complications? Because strokes and AVN and the bad things that happen with sickle cell disease, those are not fixed by gene therapy or any kind of curative therapy. It just prevents you from having more. So most of my colleagues are most of my all of us in the sickle cell space, we all realize that we don't have 30-year follow-up on gene therapy. So we don't know what happens to these patients after 30 years and that there aren't some long-term things. So it's not like we're just ignoring that point. But all of us have had patients that, were very adherent, wonderful, productive members of society who were found dead in the bathroom the next morning by their family members, completely unexpectedly with sickle cell. And so we're all pretty much believe that they should be that having multiple hospitalizations should not be a criteria for being cured. But the patients that are having more problems, it would make sense to try to get them done first, and that's what we're doing. We're looking at our whole population of patients and taking the ones that are have already shown us that they're having problems. And then on the right hand side, there are sort of the exclusion characteristics, and um, they all sort of make sense. There are problems here, though. They say they're not eligible if their baseline hemoglobin F is over 30%. We need to be very careful about this. Fetal hemoglobin isn't produced in all of the red cells, so there's this idea of heterocellular versus pancellular fetal hemoglobin. And I have patients with sickle cell disease that have more than 30% fetal hemoglobin, and their reticulocyte counts are 12%, and their hemoglobins are 8. So they are hemolyzing, and those patients are at risk. And these are patients that have heterocellular fetal hemoglobin production, and this is a specific gene mutation that these patients inherit. And so they have, you know, 40% of their cells have 50% F. So on electrophoresis, your average F comes out to be 30, but half of the cells have no F, and they're sickling just as much as a regular SS patient. A patient that has true HPFH and has pancellular fetal hemoglobin, you won't even know they have sickle cell disease because they'll be SS with 30% F, but their retic count will be normal. Their hemoglobin will be 14, 13 or 14. And they get diagnosed because they're African descent. They show up in the ER with a sprained ankle. The emergency room does sickle screening on everybody that's black that walks in there, and they find out they have sickle cell disease that way. So those patients don't need to be transplanted. But we need to be careful about that. And then the other thing is the down the list here, you'll see obviously cirrhosis of the liver would exclude you. Nobody knows what liver iron concentration is safe. But there's big concern if you have a lot of iron in your liver and then you give the preparative regimen for bone marrow transplant that they're going to get veno-occlusive disease, and that the combination of the myeloablative chemo plus the iron is going to kill the liver. And so this is what the Europeans have said, but that really isn't known. In fact, if you're going to ASH, we're doing a session on iron overload at ASH, and one of the three talks is by Emanuele Angelucci, who's a very well-known transplanter in Italy, and he's done a lot of thinking. So there'll be a whole talk on what's the effects of iron in bone marrow transplant. And so what really matters is, first of all, sickle patients do not get into serious iron problems. That's a whole other story we can talk about sometime. But they do get into trouble, but they don't get into iron trouble till they're in their, 25 or 30 years old, unlike the thalassemia patients. So it's a whole different story. So we would be, a little bit plus minus on what the exact liver iron level is, but clearly having too much iron in your liver and getting chemotherapy for myeloablation is a problem. And I think all of the other things on this, list are sort of, make sense. You're not going to transplant somebody with, who's having multiple heart attacks or has, restrictive myocardiopathy. This is interesting when you put that, patients with sickle cell disease start to develop myocardial fibrosis in their teenage years. 80% of them, if you do MRIs in sickle cell patients, they have elevated cardiac extracellular volume fractions. And so myocardial fibrosis is very common in sickle cell disease. And yeah, so I'm not, I'm not sure what we should be doing with that, but that particular number. But if they're symptomatic from heart failure due to this, then definitely we should think twice about it. But there is data in the transplant literature about myocardial fibrosis reversing in patients with sickle cell disease after transplant, but probably not severe myocardial fibrosis. So, but anyway, these are the eligibility on the left and the proposed exclusionary criteria for gene therapy, or really any transplant. This isn't just gene therapy, any bone marrow transplant are listed on the right. Um, so this is a question that everybody has. Should we use gene insertion or should we use CRISPR? And the answer is there's no head-to-head comparison yet. There haven't been enough patients globally treated. Both of these have excellent outcomes, and both of them are better than actually uh, all transplants. It's maybe you could argue it's close to a tie for match-related siblings. I personally slightly favor CRISPR approaches because it seems more natural to me. I mean, this has got nothing to do with science, but I like the idea that you modify BCL11A, a natural gene that the patients have, and you turn it back on to fetal, and that cures them. So that somehow is more pleasing than taking the AIDS virus, modifying it, and inserting a gene a hemoglobin gene that doesn't exist in nature, but nonetheless works. So the efficacy of both of these in preventing sickling is excellent. The deaths have been that have occurred have not been related to the gene insertion. There is a couple of MDS patients that got MDS, patients or leukemia, and patients with sickle cell disease have a higher incidence of leukemia than normal population. So whether this is, they did extensive workup. They even stopped the clinical trials when these two patients developed these problems, and uh, determined that none of these were related to the transgene. Um, the big thing is graft versus host disease is there is non-existent, which is a big issue. Having chronic grade 3 graft versus host disease or grade 4 is worse than having sickle cell disease. And you can see there's not been hundreds of patients treated, but there have been patients like they mentioned 42 months follow up for gene insertion, but again, there are some patients that are treated much longer than that, and who are still doing well. So there's not much difference, and period. One of the things that you um, do need to do that there's an exclusionary. I don't know if it was on the other in the United States. Having two missing alpha globin genes interferes with the gene therapy stuff. So 30% of all sickle patients are missing one alpha globin gene, and 2% are missing two. So if you should determine their alpha globin gene status before sending them, because that does exclude them uh, uh, from this. The cost is different. Gene insertion is more expensive at $3.1 million to make the product versus only $2.2 million for the CRISPR approach. Um, and this has been the big, when FDA approval occurred. I mean, and this is, first of all, it's a big deal to make these cells. I mean, the processing on this I've gone through parts of talks on how they do this. I've never been able to sit through a whole one because I'm not a transplanter, and it's boring because they go through every little detail. But the numbers of checks and balances that they do to make sure the gene products are safe is amazing. So it is expensive to do. And now most of or many insurance companies are accepting paying for this. And that's because the argument is, if the median survival for sickle cell disease in the United States is 45 to 50 years. And so from age 25 to age 45, they have renal failure and pulmonary insufficiency and pulmonary hypertension and blindness, and 25% of them wind up on dialysis. And so, the cost of managing one of these patients, not only the human cost in what the patients are suffering, but the financial cost is a lot more than the numbers that you're seeing here on this slide. And so it's felt way to be more cost effective and to do it this way. But both methods work very well. There's a little bit um, um, higher success rate with CRISPR. There are some patients that don't engraft, and that's the source of the failures. If you engraft, it works. If you look at the older data from the gene insertion, they didn't quite do as well. Their hemoglobin levels weren't quite as well, but the Bluebird Bio is a company that is doing the gene insertion, have modified their vector so that it now works a lot better, and they're getting a lot better success. So both of them get rid of the sickle crises. Now, one of the problems you have to be really careful with is it does not necessarily get rid of the pain. And so the patients have to be really clear on this, and especially in the adult world. And again, I was just in this meeting yesterday talking with there's a bunch of the sickle cell docs in the country about a new drug that's very exciting. And people want to look at incidents of pain crises as an outcome for success. It was interesting. There were, I'm going to say, 5 or 6 of the sickle cell docs in the country that are involved in a lot of the research stuff. And everybody immediately, when the company said, we want to use sickle cell pain as an outcome for whether our drug is successful, everybody says nobody can define what a vaso-occlusive crisis is. And uh, which I completely agree with. I mean, we've done a modest amount of research trying to understand sickle cell pain, and I can't tell what is a crisis. And no, I don't think anybody can. In kids, it's a lot more pure. You have sickle cell vaso-occlusion. When we understand that physiology very well, we have no idea why vaso-occlusion causes pain. I mean, everybody just says, "Oh, you block your blood vessels and that causes pain." But why? We don't know why. And they then get neuropathic pain. And so the patients come to the emergency room complaining of worsening pain, and this doesn't necessarily mean they're having a sickle vaso-occlusive crisis. They can be having exacerbation of chronic regional pain syndromes. And and all of this gets perceived as pain, and then trying to figure this out, what the patient complains to of when they come in and how they react to you in the emergency room doesn't just depend upon the patient. I mean, I can tell you horror stories of things that physicians have said to patients with sickle cell disease. I mean, they are treated like crap in certain places. We've published a bunch of stuff showing that anxiety triggers pain crisis, and we know the mechanism of that. Um, and so if you are going in there and somebody comes in and accuses you of being a drug addict, even if anxiety in psychological state modulates the perception of pain in patients that don't have sickle cell disease. So it makes it very difficult to figure this out because it not only depends upon what's going on in the patient, but it also depends on the healthcare providers taking care of them, and the social milieu that the patient is in and what kind of support they have. So we can't figure out what their crisis rate is. If you want to talk about pain events, due to all of the different things that can be happening in sickle cell disease, that's a different deal. But the number of pain events that you're having from neuropathic pain has got nothing to do with whether you're having, well, very little to do with whether you're having sickle cell mediated vaso-occlusion. And that's what this CRISPR stuff does. It stops you from having sickle mediated vaso-occlusion. It is not a pain treatment. So patients that go into gene therapy with severe chronic regional pain syndrome, it is not going to be stopped right away by fixing their hemolytic process. Now, chronic regional pain gets worse with continued vaso-occlusive crisis, and so there is some relationship, and over time, measured in years, the pain can get better for those patients. But this hospitalization-free, vaso-occlusive-free, those endpoints are completely imaginary. The FDA and the people that put those in there, this was a discussion we just had yesterday. It's not a good endpoint to use. Um, yeah, you questioned about the stem cell sources, the three stem cell sources for transplant I listed along the top. Um, and cord blood, that, if you weigh more than 35 kilograms, there's not enough stem cells in the cord blood to do a transplant. So that's really not an option for adults. And we actually don't use it in pediatrics. Really, people store the cord bloods on their children, but it's not a common that we use it for a number of reasons. Bone marrow itself doesn't have very many, stem cells, but the big issue is that with it is it has a lower GVHD rate, and it also has a somewhat lower transplant-related mortality. So it's the stem cell source of choice for regular transplant in patients with hemoglobinopathies. Apheresis is the source of choice for gene therapy because you get a lot more of the stem cells by doing that way. You have faster engraftment. The GVHD with stem cell rate is apheresis is chronic GVHD is higher, but this is not the case with gene therapy. Um, for gene therapy, it's apheresis is what's being done for regular transplant. It's harvest from the bone marrow, and it takes usually down at the bottom in terms of donor burden. Uh, it's almost never just one session. 2 to 3 sessions of 6 hours each of apheresis to get the stem cells done. So give the disclaimer that I am not a transplant attending, but I think these are well known to most people. Busulfan, Bucy is the usual preparative regimen that people have used, and it has a better result than some of the other ones. There is some work going on with reduced intensity, but because of the marked hyperactivity of the bone marrow in these patients with sickle and with thalassemia, they have to use really highly myeloablative. And the biggest issue here is there's a very high risk of infertility. It's not 100%, but it's pretty close. And especially with sickle cell disease, people that aren't often, well, nobody can. It's like $30,000 or $40,000 to harvest eggs and go through that whole process. And so most of it and not covered. Pulmonary fibrosis with busulfan is a well-known complication, so I think we're all familiar. One of the biggest issues is the veno-occlusive disease, and one of the questions that the transplanters always have is what's the relationship between severe VOD and their iron loading? Because what happens is when you give these drugs, busulfan really affects the glutathione pathways, which is what the basis of busulfan pulmonary fibrosis is. And Also, you lose your antioxidant protect, well, one of your major antioxidant protections with this stuff. And hydrogen peroxide plus iron through Fenton chemistry gives you, amplifies the oxidant damage from these things by 100-fold. And so if you have a lot of iron overload and you give intensive myeloablative chemotherapy, then your risk for iron toxicity, particularly in the liver, is a lot higher. Um, all right. You ask what's the recommended monitoring of post gene therapy. At our place, that we have a survivorship program in pediatrics where systematically Dave Fryer is our guy here, and I don't know whether that may actually be interesting to you as well. Dave has a actually is there's a national pediatric international group actually of people that are their main focus is how do these children do when they leave pediatrics? And so they follow them well into the adulthood to try to find out what the long-term complications are. And I'm not involved in that program, but it's very organized and trying in peds, trying to get them as connected with adult hematologists to follow a lot of these diseases. And so monitoring iron overload becomes a problem that we want to get rid of all the iron right after the transplant, but after that, it should not be a problem. And usually, this is in our center. This is done right away to get rid of the long term because long term exposure to iron has lots of risks like second malignancies. Um, and basically, this is straightforward recommendations of the European group of what they do, and they're monitored for now regular from a regulatory standpoint. They have to monitor them for 13 to 15 years for the gene therapy products because they're concerned about long-term complications of the gene insertion. So this continues for a while, and I'm not going to read through the whole slide, but it's fairly straightforward. The frequency of what's being monitored and uh, again, we have a separate in our place. We have a separate clinic that does this, not just for all bone marrow transplant patients. Who pays for this? Yeah, I think I already talked about this a little bit. The insurance companies are coming around. It's very expensive, and the number that I always remember is that there's 250,000 children a year born in Africa with sickle cell disease, and 80% are dead by their second birthday. And they don't have $2 million there to be cured. So, in rich countries in Europe and the United States, the insurance companies are stepping up to pay for this. Um, and the discussion about access to care and racism and all those things that revolve around patients with sickle cell disease. Uh, that's a, you know, it's a 5-hour seminar about how to approach that.
That was great. That was very comprehensive. I just had a couple questions. You mentioned about the importance of alpha globin testing
Yeah,
for
yeah.
these gene therapies. Is that mainly for the gene insertion strategies where that's important?
To be truthful, it's one and not the other. And right off the top of my head, I think it's the Casgevy.
Mhm.
And I can't tell you why. There's something that didn't work with one of the patients or that they were blaming an alpha globin, and it doesn't make any sense to me. I just can tell you that we have an interest in alpha globin anyway in sickle cell disease. That's another whole very, very interesting story. Alpha globin is expressed in small arterioles and regulates blood flow. Um, and patients that are missing alpha globin genes have increased blood flow actually. But I don't know what the difference is. I'm pretty sure it's with the Casgevy. If you have two genes, not one, 30% of sickle patients are missing one alpha globin gene,
Mhm.
but only 2% are missing two. So,
That's important. And then, as you noted in one of the previous slides, cerebrovascular events are contraindications for, or were listed as contraindications in the studies for gene therapy. Have
Yeah.
aware of any patients that have undergone gene therapy that have had neurologic events, or I know that's an active area of interest, but
Yeah, it's not an absolute. So, silent strokes aren't a a contraindication, and major strokes with CNS would be. And in general, I don't know what the whether adult transplant for malignancies, whether stroke is a contraindication or not for auto transplant for malignancies. Um, but it's not an absolute. But what happened with some of the original trials and some of the original bone marrow transplant trials is that there was a cerebral hemorrhage when the patients were thrombocytopenic during the preparative regimens, and so that people were and deaths. So they're very hesitant to transplant somebody that has significant cerebral vascular disease for those reasons. Yeah.
thank you,
Well,
Dr. Coates, for
yeah.
for your time and your generosity. I
Yeah.
appreciate it very much.
Well, it's always good to see you guys. You're doing some good work.